Hello again to those of you who have been joining us every week, and welcome to those of you who have not. I am Dr. Martin Rutherford, and I am a certified functional medicine practitioner. I'm also a chiropractor since 1979.
Dr. Randall Gates, I'm a board-certified chiropractic neurologist, as well as being a chiropractor.
And for those of you who are new to our presentation, we have a functional medicine practice that has combined the disciplines of functional neurology, working with the brain and the nervous system, which basically control everything, and working with functional medicine, which works with the physiology of the rest of the body. It works with common things that people have, diabetes type 2 and other blood sugar problems and kidney, liver, all that type of stuff. But what we seem to work with most these days are autoimmune problems. So our two disciplines have melded together to address some of the chronic pain issues that are out there. And it turns out that we've developed pretty much a chronic pain practice. And we get people who come here with chronic pain, fibromyalgia, peripheropathy, chronic fatigue, dizziness, vertigo, balance, migraines, restless leg syndrome, and we can go on for a little bit there. So what we're doing in these presentations is sharing our findings, clarifying topics that we had to dig through to find out what was actually correct about certain topics so that they could be applied clinically to a patient and that they would work. In our office, if you take vitamins and you come into us and I say, are those vitamins helping you? And you say, I don't know, but I'm taking them for prevention. I'll tell you, you should probably stop taking them. one of those little clinical pearls that we have come to find. Sometimes the vitamins aren't working because you're not taking enough. Much of the time they're working because you read it in some magazine that you should be taking these, and you can't conceive that the magazine makes an argument that you couldn't possibly make them or get them from your food or whatever. And so much of the time that's BS. We can talk about that on another day. I think we have talked about that in one of our hangouts. So we're trying to present this information, and today we're going to talk about iron and B12 deficiencies. I think we've talked about these before, kind of obliquely, but today we're gonna expand that, and we're gonna talk about how it affects H. pylori. You know, it's funny when we talk about H. pylori. I remember when I was just doing chiropractic, and I had this one patient come in, and he was having a kind of a diaphragm problem, and I kept working on it, and I said, "There's something else going on." So he came in one day, and he looked up at me, and he said, "Doc, I have H. pylori." He said it like he had cancer. You know, it was like, oh my God, this discovery of the universe. And although I kind of, it was just the moment, you had to be there. But in the chronic pain world, we see it a lot.
Right.
And it's important, and it's more than just the bacteria that inoculates your gut and your stomach and maybe your duodenum. And it's one of those entities that we've become aware that really are important in the complex issues of treating chronic pain.
Right.
And it has a lot of ramifications. Well, you have to take one step back to iron and B12 if you want to really completely evaluate H. pylori. So a lot of patients will come in, I got H. pylori, I took antibiotics, it went away. Did it go away? Did you get it retested? No, I didn't get retested. How do you know it's not there? Dr. Gates gave me his outline because he prepares all these things. I didn't see anything, maybe I'm wrong here, on how if you have an H. pylori and you try to fix a leaky gut and you don't fix the H. pylori, how the leaky gut's going to probably come back, and maybe you are going to go through this. So there's a lot to it, and we're going to get into it now. I think this is going to be really interesting. I was really excited when Dr. Gates told me this was going to be a topic, because I hear this all the time. I hear it in the histories. I hear it in the exams. I hear it when people sneak around behind Dr. Gates's back and go, does he really know what he's doing? They don't do that. I just wanted to make them laugh. So people say, Dr. Gates is really serious, huh? So I just wanted you to see he can laugh. Okay. Gotcha.
Oh
So,
goodness.
so let's do it.
Okay.
So let's talk about H. pylori. I think I
Mhm.
just covered like why it's kind of important for
Mhm.
the chronic pain sufferer. If you have H. pylori, you have chronic pain, there is an awfully good chance that it is one piece to your puzzle relative to what's creating your symptoms. And I can go on to that forever, but Doug Gates has a much more organized and approach to this than I would have. So let's talk about H. pylori. What is it?
So H. pylori is a bacteria, and it lives primarily in our stomach.
That patient said, I have Helicobacter pylori. He said it like, oh my God.
And you're thinking, oh dear God, what did I miss?
Well, at the time, at the time I was like, okay, this was like 20 years ago.
But you weren't alone, because no one acknowledged H. pylori at that point.
Exactly.
Yeah, so H. pylori is a bacteria, lives in the stomach, can live in the small intestine, and it lives in the stomach where bacteria should not be able to live. So the stomach is very acidic, extremely acidic. And so it's acidic so that we kill things like bacteria. However, H. pylori, or Helicobacter pylori, produces something called urease, which is basically an alkaline substance. So it nullifies or mitigates the acid in your stomach.
So for the acid alkaline folks, you're supposed to have acid in your stomach, like a lot of it. Like it digests your protein, but it kills a lot of the bad stuff. It's kind of like the guards to the gate of your intestines. It's kind of like you need to kill these parasites, you need to kill these bacteria, you need to kill these things, and this acid and digest your proteins. And this acid is what does that. And when that calms that acid down, that's not a good thing. For those of you who are in the alkaline thing, intestines need to be alkaline. Stomach needs to be very acid.
Yeah? Exactly.
Okay.
Exactly. Perfectly said. And when your stomach isn't acidic, then you can develop a host of problems. Even you can get too much bacteria growing in your small intestine, something we've talked about ad nauseum, called small intestinal bacterial overgrowth, because then they just have a party in there, and that can create belching and bloating and indigestion and constipation, and it goes on and on and on. So
that was probably the early 90s when that patient told me that.
Yeah, no, okay, it was right when it came out.
Okay, I was just going to say, so when was it?
It was officially discovered.
I don't feel like a complete idiot.
Back, I think, in 1983 was when it was first discussed.
This was about 93.
Yeah, and then there was a gentleman, it really hit medicine and the media when a doctor who was working on this said that H. pylori was causing ulcers, because before the early 90s, everybody thought ulcers were just caused by stress. And so he actually inoculated himself with H. pylori, meaning he ate H. pylori bacteria, developed ulcers. He had it proved via an endoscopy. That's where they stick the camera down your throat. Then he took antibiotics. And
that is a dedicated researcher.
Yes. And so I watched the 2020 special. I must have been, I don't know, 10 at that point.
And you remember
this? I remember this, of course. So, so anyways, after this, it became widely acknowledged slowly throughout our society that H. pylori causes things like stomach ulcers. And then from there, now we have a ton of information on H. pylori and the widespread effects it can have on the body.
And it's a big deal.
It's a huge deal.
I mean, so everybody's watched. I've had ulcers and H. pylori. Too. He's had H. pylori.
Yes,
too.
I have, actually.
And tons of our patients have had H. pylori. And it's a big deal. And I don't know that it really gets the kind of the attention, other than you got H. pylori, take this and see you later, that it really deserves, especially in the framework of our patients, of our patient population of chronic pain patients. I'm talking pretty much everything I mentioned in the beginning and then some, whether they have restless legs, or whether they have neurological brain problems, or whether they have fibro or immune problems, any of that type of stuff. So it's a big deal. How common is it? How common is it?
Incredibly common. The estimates vary. 30 to 50% of the population in industrialized countries like America, upwards of 80 to 90% of the population in non-industrialized countries. So it's very, very common. In fact, now we're finding that a lot of people walking around on this planet have H. pylori. And we'll explain why it's a problem for many of you. And maybe some people can have it in their stomach and they can kind of get by, so to speak.
Okay.
Yeah.
So we already kind of mentioned, but specifically, It can cause problems with the stomach.
Yeah, ulcers. It can cause
cancer.
gastritis. So all you gastritis sufferers out there taking omeprazole, proton pump inhibitors, you need to know that H. pylori is a major cause of the stomach inflammation that you have and that acid indigestion you get. H. pylori is associated with gastric cancer. It's also associated with something called a malt lymphoma in the stomach. It's another type of cancer that affects the stomach. So if you have any stomach condition, you really want to push your gastroenterologist to look for H. pylori. And I think because it is so common, lots of times gastroenterologists are paralyzed by whether to treat or not to treat. Because if you have gastritis, most commonly they're going to give you an acid blocking medication to calm down the inflammation in the stomach. And we attached an article where they discussed H. pylori is a major issue. It causes A through Z conditions, you know, a variety of things that we're going to go through. But if we treated everybody, it would cost $32 billion and maybe people would develop antibiotic resistance. So we don't know what to do yet.
And this is an important point because once you go down the road of acid blockers, that's a whole nother animal. And you start doing all these Previses and all the purple pills and all that type of stuff. It creates a whole new chemistry in your body, and it's not good because it's killing the acid in your stomach, and you need acid in your stomach to digest those proteins. And a lot of you go, well, how could I need acid in my stomach? It's messing up my esophagus, and so I got to take that. No, it's the acid that's messing up your esophagus is because you're not digesting your proteins. And so it's sitting there putrefying, and then it gets acidic, and your nice alkaline intestines doesn't want it. And next thing you know, you start getting this acid indigestion. So what do? You either have H. pylori or you're not digesting your proteins. And the next thing you know, you're taking something to kill the little bit of acid that you have left. And now that sets off a whole cascade of problems, which we should probably do a talk on that.
Yeah,
because that's easy an hour.
Yeah,
that's a huge one.
That would be a good one.
So that's H. pylori. But our topic is iron deficiency and B12 deficiency as it relates to H. pylori. And this is a big one because we see some of the things that Dr. Gates has down there we're going to talk about, particularly anemia of chronic inflammation, we see all the time. And I think that's a big subject based on the confusion that I see in the patient when they come in on the consult. It's kind of like, well, I got this anemia for my whole life. And and I took iron and I got worse. Or they don't know what it is. They just keep telling me it's okay, it's normal. Or what anemia, trust me, is not normal. You don't want to have it. And it's something that really almost needs to be fixed if a person wants to get better. So let's get into iron deficiency anemia.
Okay.
This is one that seems to be a little bit more well understood by the patient population that's coming into us. And when we talk about how your doctor recognizes it, what are the signs they look for? When we go from there.
Okay, so basically there are 3 stages of iron deficiency, and it's based on ferritin as well as how many red blood cells you have. Ferritin is a marker of a stored form of iron in your body, and we can measure it. So basically it accounts for about 30% of the iron in your tissues. And stage 1 consists of you just having a moderately low ferritin.
So I'm going to interrupt here. Some of you love and some of you hate, but I'm going to interrupt here. Okay, so most people who come in have no clue what ferritin is.
Right.
Okay, so Dr. Gates kind of, he defined it. However, what you need to know is when you go to your doctor and they do a complete metabolic panel, okay, that doesn't particularly include
ferritin.
Exactly. It includes, so iron has multiple aspects to be evaluated to determine what it's doing in the body. Most of you come in and you go, oh, my iron's fine. They took it and my iron is fine. There's ferritin is the stored iron in your cells. There's going to be a total iron binding capacity. There's several other things that are going to tell you long before your iron looks bad, gets low, that you are already maybe getting into iron deficiency. So just that ferritin is a big deal.
And that's a great point because basically hardly anybody tests for ferritin. I was going to go
And
to
that is
so
the point.
basically, if your iron's been tested, as Dr. Rutherford said, maybe they ran an iron, which is how much iron is in your blood. That accounts for about 1% of the iron in your body.
Because the insurance companies
Because
don't want you to run a full iron
Yeah,
panel
exactly.
due to the massive cost of it.
Yeah.
It was like $100 or something.
Oh no, it's God. Well, yeah, maybe for them. I think we get an iron panel with ferritin for about $8.
Yeah, we get testing for like,
Really,
I shouldn't tell them. We get testing for like 80 to 90% off. We'll have all these people sending us stuff now. Can you test for this and test for that?
We did a whole broadcast on why you may be charged more.
Yeah.
By your insurance company. Yeah. But anyways, so in essence, ferritin is not commonly tested for. However, it's the standard recommendation to test for it, but your insurance company may not want to pay for it, so your doctor can't test for it. So ferritin, we were just talking about this. There is a low value for ferritin. Usually it's below 15 or 12. However, they say if it's below 30, kind of low normal, so to speak, it's an issue. And we were discussing before the broadcast that a lot of medical doctors are now becoming more accustomed with what are termed functional norms, which are norms, frankly, created by Dr. Harry Eidner, who's we have a great picture with.
Go Harry.
Yep. And he did this study of 10,000 people over 10 years back in Michigan, and basically was able to predict if somebody had these functional lab abnormalities, whether or not they would get a disease like a severe iron deficiency anemia or other markers related to cancer. And it's really awesome data.
Yeah, they were adopted by the American clinical
Society of Clinical Chemists, something like that.
Yeah. And they really didn't get into the medical world. This is where functional medicine started, frankly.
Yeah.
With these norms. And now I just noticed recently that more doctors are starting to even use the terms. You're in the low end of normal. You're in the high end, and that didn't happen as little as 3, 4, 5 years ago. Yeah. So the ferritin numbers are important.
Absolutely. And so basically stage 1 is if your ferritin's below 30. Stage 2 is if your ferritin is below 12. Stage 3 is if your ferritin's below 12 and you have anemia. So many times most of you will come and say, well, I'm not anemic. I don't have an iron problem. Well, by the time you're anemic due to iron deficiency, you have a major iron problem. You had an iron problem for a long time. And so that's how it's really classified, and that's how it's acknowledged. Yeah. So if you think that you may have an H. pylori issue, you need to press your doctor to make sure that your ferritin's being checked.
Okay. Yeah. And how does the iron deficiency relate to the H. pylori?
So basically, no, and so we'll go into that now. So basically the H. pylori initiates an immune response. And what is thought to happen is that your liver, your little liver cells called hepatocytes, don't make enough of this hormone called hepcidin. Hepcidin is acutely involved in regulating how much iron you absorb from your gastrointestinal tract. So basically how much iron goes from your food and your intestines into your bloodstream. And H. pylori throws off that hepcidin molecule. So hepcidin levels change when you have H. pylori, and therefore you won't absorb as much iron. And that is really the causal mechanism for somebody being iron deficient or iron deficient anemic because of H. pylori. So it's really cool. In the studies, we put down here a quote in the literature, they talk about H. pylori should be sought and eradicated. And if you have iron deficiency anemia, as Dr. Rutherford said, if you're chronically anemic and you just don't know why, boy, you need to be tested for H. pylori.
I said that, I think, before the presentation.
Oh, you did? Okay.
Or maybe I didn't. I don't know. I think I said that we talked before the presentation. But yeah, I did. It was before. It was before. So basically what he's saying is the patient that comes in here, it says, I've had anemia all my life, but nobody really knows why. Nobody's ever told me why. Or I took iron and I felt worse. Well, no, that would be fair. That would be high ferritin. Bad on me.
Okay, we see a lot of that too.
But we do see a lot of that. We do see a lot of that. But we see a lot. So we see a lot of iron. The point I wanted to make was we see a lot of iron deficiency, essentially secondary to chronic inflammation or autoimmunities. But you should be looking for H. pylori in those cases. And the point I try to make the patients is what is the battle there? Is the battle the iron deficiency anemia, or is the battle figuring out what's causing the inflammation or the autoimmunity? And then that goes into, is there an H. pylori there? Mm-hmm. Would that be a correct flow?
That is correct.
Okay.
Yeah, no, that's correct. Yeah.
No, so I'm just trying to draw the picture for the patient that walks in is sitting down with their blood tests, and you know, half of the time, a lot of people will bring their blood tests and they won't even mention that they have that iron deficiency anemia, and so I'll point it out to them in their blood test. Oh, it's been there my whole life. My doctor says it's normal. It's not a problem. Why is it a problem to have iron deficiency anemia when we're trying to fix somebody?
That's a huge problem. I mean, if you have restless leg syndrome, we've talked extensively ad nauseum about that. A huge percentage of the population has restless
leg syndrome. Or just the inability to make energy.
And that too.
Just the inability to make energy. I mean, if we're going to get a chronic pain patient better, their cells need to ultimately be able to make energy. What is one of the first signs of anemias? You're tired. Right. You're tired. Some people are chronically tired. Some people are profoundly tired. That means that the iron is not getting any oxygen to your cells, and your cells, those little things called mitochondria in your cells that make energy, aren't making energy. It's kind of hard to bring a person back to balance or homeostasis when you have that situation. In fact, when we first started out, and this is before you were here, when we first started out in functional medicine, our first step was if there's an iron deficiency anemia, you fix that before anything else. Because if you don't fix that, a patient's not going to be able to respond to anything else. We've since morphed into the gut because of the increased clarity that we got on anemias. And that's what we're talking about here, that increased clarity that we're talking about anemias. Yeah. And chronic gastritis.
Yeah. And,
about that.
And relative to restless leg syndrome, 1 out of 10 individuals basically have restless leg syndrome. Iron metabolism is highly important relative to that. And so a lot of restless leg patients have decreased iron stores in their body. Again, you got to look for H. pylori. Relative to chronic gastritis, I kind of mentioned it obliquely before, but basically when you have H. pylori, the stomach can get inflamed, and that inflammation can lead to minor amounts of bleeding in your stomach. And that can also result in the causal mechanism of you having iron deficiency anemia, because basically you're bleeding in your stomach. Things you want to look for are the colors of your stools. If your stools are black or they look like charcoal and they're tarry, you need to tell your doctor right away. There are easy tests that can be run to figure out if you are bleeding into your intestines or your stomach, and that needs to be treated pretty promptly.
And that H. pylori test is a breath test.
There's a breath test for H. pylori.
That's pretty accurate?
Yes, that's the most accurate. It's called the urea breath test, because basically, as I said before, H. pylori makes urease, which urea. And then also there's an antibody test for H. pylori as well. It's not as sensitive or specific, but it's still a pretty good test. It's about 74% on those numbers. So it is useful. However, people will argue that if you have the antibodies, perhaps it was an old infection versus an active infection. However, other people argue, well, you know, upwards of 90% of the world's population has this. So you probably have it if you have the antibodies. Yeah.
So it's easy to test for.
Yeah.
It's easy to test for, and it's not expensive. And if you're having any type of gastritis, it's something you should look for. And I might say also, I ask people when they come in, is it gone? And they say, I don't know. Should they test afterwards?
Yeah,
I think yes. Right. Because if that is remaining, if that is there, it can create gut problems. It creates ulcers in your duodenum. If you create an ulcer in your duodenum, which is the upper part of your small intestines, if you create ulcers there, you're violating the integrity of the intestines. Right. For those of you who are fans of alternative care, you know what leaky gut means. It's one of the things that contributes to leaky gut. So for those of you who've gone on the web and found out the leaky gut diet and the leaky gut herb, and you did it and felt good for 6 weeks, and then it came back, and you still have gastritis, and you're still trying to take something for it, you have to look at this. Because if you do that, and you don't get rid of, if you do that protocol and you don't get rid of the H. pylori, it's just going to come back, because this is maybe part of what's creating your leaky gut. Okay. B12 deficiency and H. pylori infections.
Okay.
Or were we done with?
Yeah, I think we pretty well covered iron.
Yeah.
And we'll add on a little bit to the end of the outline. I've got some other ideas.
Okay.
And again, now we're going on to B12. Thank you, Becky, our biggest fan down in well, I won't say where you're at, but thank you again for asking about B12. So we'll do more on B12, but I just wanted to tie B12 into this topic. And I think that this will kind of give you a good overview of B12 too. So B12 is officially diagnosed via measuring how much B12 you have in your body. So that's step number one. And basically, if you're below 150 or 200 on your B12 reading, you probably have a B12 deficiency. But it gets a lot more complicated than that. And frankly, that's not really the best way to survey somebody for having B12 deficiency. Better ways include markers called homocysteine and methylmalonic acid. Homocysteine, probably a lot of you have heard about. Homocysteine is an inflammatory marker, and it is associated by some with cardiovascular disease. Also, methylmalonic acid is another byproduct of B12 metabolism, like homocysteine. And so when B12 goes low, homocysteine and methylmalonic acid go up. And unfortunately, a lot of doctors in our experience don't test for these markers, again, because insurance less commonly pays for them because they're more expensive. So lots of times people are taking B12 or they have a B12 deficiency and they just check their B12 levels. And I can't tell you how many labs we've looked at where B12 is high on the lab because the person's taken it because they had signs of a deficiency, yet their homocysteine or methylmalonic acid are up.
Right.
And so that can create some ambiguity. In essence, there are different stages of B12 deficiency, very analogous to iron deficiency. In essence, it's going to go down in your blood. B12 will go down in your blood first. Then it's going to go down in your tissues. Then you're going to see signs of elevated methylmalonic acid and homocysteine. And then ultimately, you're going to develop anemia secondary to vitamin B12 deficiency. This is kind of an opposite type of anemia from iron deficiency anemia. In essence, in iron deficiency anemia, your red blood cells get small, whereas in B12 deficient anemia, your red blood cells get big. And there are markers on your blood panel that doctors can look at to tell if you have an iron deficiency anemia or a B12 deficiency anemia. And we see a lot of B12 deficient anemia. And
we see a lot of sick people.
We see a lot of sick people. And in terms of what percent of the population is affected by B12 deficiency, ranges from country to country, but conservative estimates are 20%. 20% of the population has a B12 deficiency. That's really striking. And other estimates say as high as 60%. Obviously, let's take a step back. And we've talked about B12 before. B12 is in animal products. So meat, poultry, even dairy products, eggs have B12. And so when you eat that B12 rich food, it goes into your stomach and it needs acid for the B12 molecule to be cleaved, as they term, from the proteins. If you don't have enough acid, then guess what? You're probably not going to be able to extract the B12. That has come out in the neurology literature, especially as it relates to neuropathy, which B12 is associated with, such that for all of you taking Prilosec or proton pump inhibitors, that can be a cause of low B12 because you can't get the B12 out of your food, even though you're eating lots of B12 rich food.
One of those things that they said that goes off into a whole nother direction once you start taking these medications. A lot of bad things happen if you take them long term.
Exactly. And then
we're not anti-medicine.
No,
I know we say that every week, but for those of you who may just have joined us, let me just say, we're not anti-medicine. We work in an integrated environment. We have an osteopathic doctor who works in an alternative cancer clinic who comes in here and works with us. So we're just letting you know that long-term use of those medications is not a good thing. There's just one of the many major bad side effects of taking those long-term.
And once that B12 is cleaved from the protein in your stomach, so now it's sitting there, your stomach makes chemicals, one called intrinsic factor, that is produced out of your stomach, and then the intrinsic factor and B12 travel down your intestines until the last part of your small intestine called ileum. And that's where the intrinsic factor binds onto the B12 and goes into your bloodstream so that you can have B12 in your system. What we're going to talk about is that a lot of patients who have B12 deficiencies have something called pernicious anemia, which is where the immune system kills the cells in your stomach that make the intrinsic factor, or the immune system starts to kill the intrinsic factor itself. And once that starts to happen, then you can't absorb B12 no matter how much you're eating. And as a result of that, you're going to develop B12 deficiency, and ultimately possibly pernicious anemia. Pernicious anemia and B12 deficiency are bad, especially neurologically, because it can be associated with a wide host of problems like dementia, depression, peripheral neuropathy, spinal cord issues. Can also be involved with cardiovascular issues, B12 deficiency can. So your B12 status really needs to be looked at. And just to summarize again from that perspective, not only does your B12 need to be tested, but also your homocysteine and your methylmalonic acid. We'll say, the research says that if your homocysteine is above 13, you have an issue. In our opinion, if it's above 9 or 10, you have an issue. Yeah.
Just based on what we're saying. So you can get it by being a vegetarian. Right. You can get it by having an autoimmune problem, this pernicious anemia, where the intrinsic factor gets down. That's your immune system is a problem. You can get it by poor absorption. You can get it by lack of hydrochloric acid in your stomach.
Mm-hmm. Other gastrointestinal diseases like celiac disease
that cause you to not absorb it. Yeah. Right. So those are the things. And if you're taking B12 and it's not working, you probably have lack of absorption or an autoimmune problem or something along those lines. If you're taking a lot of B12 and it's not coming up, then you need to start looking at these other things. And all of these pieces to the puzzle are what you have to look at when you're trying to bring any type of a chronic pain patient. By the way, chronic pain means you've been in pain for more than 6 weeks. I've heard some people say 3 months. I've heard some people say 6 months. Once you've been in pain for that long, you have systems that have decided they're not coming back, and so some of the things we're talking about are the pieces to the puzzle that have to be teased out and directly affected. And this is a big one. Mm-hmm. And this is a big one, the iron deficiency, and it's a big one, I think, even bigger, because it kind of gets I don't know if I want to say blown off in the medical model, but it's certainly not ascribed the importance that it has in trying to work with patients who have chronic problems. So relative to H. pylori.
Mm-hmm. How does it work? Yeah. So in essence, what happens is that when you have H. pylori in your stomach, and if you have the genetics to be predisposed to this condition, combined with the epigenetics, where basically we know that a certain segment of the population is predisposed to autoimmune disease, but then by the other side of the coin, 1 out of 6 Americans now have an autoimmune disease. 1 out of 4 women have Hashimoto's thyroiditis. We have this explosion of autoimmune problems. So it's not just genetics. There are environmental factors going on, causing this epidemic rise of the immune system killing the person. So H. pylori in a number of individuals will cause the immune system to start killing the stomach. And it's basically a 1-to-1 ratio. So H. pylori is there in those individuals. The immune system tries to kill the H. pylori. It gets overreacted because the H. pylori looks like the stomach cells that make the intrinsic factor. And the immune system then starts killing those cells also in order to get rid of the H. pylori. Furthermore, the immune system will kill the intrinsic factor. And as a result of this, the lining of the stomach becomes shrunk, basically. They call it atrophic, because the immune system is killing the heck out of the stomach like it's a foreign invader. And that can be associated with what's termed autoimmune gastritis. If you've been diagnosed with that, that's in essence what's happening, which is basically going to lead to pernicious anemia.
And you need to take antacids.
Yeah. I could tell you were thinking something.
I'm always thinking, when I'm listening to you, I'm always trying to put it together with what I'm experiencing here.
Take your antacids and see you later. Don't let the door hit you on the way out.
Yeah. I would say with that sometimes to a patient who's in here kind of putting you through the steps, and they don't quite get what we're trying to say to them. But so sometimes my New Jersey,
it's good,
humor comes out, and sometimes it's not appreciated. What can I tell you? So we've been talking about iron, B12, and H. pylori now. And those of you who saw me look at my watch, it was for me to see that we've been talking about it for like 45 minutes.
Yeah.
And if you go, and so part of the problem of the expanding autoimmune population in this country, which thank God people are starting to become aware of, and the alternative doctors are starting to become aware of. And I think it's even starting to creep into the medical community a little bit. So, but when you go to the average doctor at this point in time, you have an iron deficiency. It's like, you got an iron deficiency, take iron. You got a B12 deficiency, take B12. You got H. pylori, let's take some antibiotics, get rid of it. And that's pretty much it. As you can see, there is substantially more that has to be evaluated to determine, again, where is it coming from? Where is it coming from? And fortunately, we in this office have always had that kind of like, okay, why is this not getting better? Chiropractor. I did chiropractic for way many years before I got into functional medicine, and going through these types of problems, like the gentleman I talked about. He had H. pylori. He also had a problem right in through here. Mm-hmm. And his H. pylori was affecting his diaphragm, because it was getting inflamed. Your duodenum sits right below where your diaphragm is. Your diaphragm is a big muscle that runs around here. And you breathe and it goes down, goes up. And it was causing his diaphragm to contract basically as a protective mechanism. And it was causing him to have mid-back pain. And I was adjusting him for weeks. And if I say, hey, Brian, I said, this is not going anywhere. Brian, you're probably not watching. But if you are watching, I said, this is just not going anywhere. We got to find something else. And that was pretty interesting, because I'm going to tell you, he now, knowing when things were discovered, he kind of rolled over on the table one day and said, I finally figured it out. We're going to get this done because I have Helicobacter pylori. That's exactly how he said it. Brian, if you're watching, you know that's how you said it. And I was like, okay. And he's taking the antibiotics, and all of a sudden, within 2 or 3 weeks, adjust him once or twice, and he was fine. Just to show you, even chiropractically, when you're going to the chiropractor and maybe your adjustments aren't working and you're being told well, it's just going to take 6 months or a year and a half. And you kind of sort of maybe have an inkling, and I'm not selling out chiropractors, because I'm just referring to whatever percentage do this. And you have an inkling there's something else, and you have a mid-back pain. Well, you wouldn't know to look for H. pylori. And you ultimately wouldn't know to look for the B12 and the iron deficiency things relative to it. And these are some of the fun developments in functional medicine, and really, really getting down into what's the cause of the problem.
Exactly.
And so that was the cause of his problem. In retrospect, who knows? Maybe he had iron deficiency or B12 too at that point. But he did get better after he took the antibiotics, and he responded to his adjustment. It's all one body, folks. It's all one body. To me, functional medicine is about getting that body back into balance in every way, shape, and thing you can find to get that person's body functioning normally again, with the least amount of intervention possible. That means supplements, that means drugs, that means all the types of things, so that that body can kind of start to function on its own and not be dependent on its own. And that's really the excitement to me of this, because this is a big blind spot in the patients that come in here. And I think in the doctors who were treating them prior to that.
Yeah, I wouldn't disagree based on what we see.
Yeah.
And so, as Dr. Rutherford alluded to, H. pylori is commonly eradicated with a couple antibiotics. The common regimen is clarithromycin and amoxicillin. We're not telling you need to take that. I'm just letting you know what it is. And they commonly put people on an acid blocker while on those medications, but not usually chronically.
Right.
And then there are natural alternatives to that too. We work with some of them. They have mastic gum in them, which has been shown to help get rid of the H. pylori. Also, there are diets that help to get rid of H. pylori, primarily a vegetable-based diet, as we say every week. So a vegetable-based diet has been shown to help improve an H. pylori infection. In essence, what you should see is once this bacteria is eradicated, and the iron deficiency should improve, the B12 deficiency should improve. That has been substantiated time and time again in the literature. H. pylori is this whole universe, becoming this whole universe by itself too, because we now know H. pylori through this mechanism of what's termed molecular mimicry. Like I said before, the H. pylori looks like your stomach cells. Your immune system starts to kill the H. pylori. As a result, your stomach cells start to get killed. It appears as though patients who have Sjogren's disease, which is a autoimmune condition against the ducts in the eyes that make tears, as well as the salivary glands, the immune system kills them because apparently H. pylori looks like them from a molecular standpoint. There's something called antiphospholipid syndrome, which we've seen a few cases of, where
we just saw it.
Okay, Yeah, that's right. That's right.
Yeah.
You told me about that.
Yeah.
And so that's where you make antibodies or immune cells to your blood vessels, and it can be associated with blood clots, something you want to have figured out pretty quickly. H. pylori is now being associated with that. Thrombocytic purpura, idiopathic thrombocytic purpura, that's where your immune system kills platelets, also now associated with H. pylori. Monoclonal gammopathies of uncertain significance. If you watched our neuropathy talks, this accounts for 10% of idiopathic neuropathy. Now H. pylori is being tied to causing the immune system to get so dysregulated and cause the nerves to get attacked because of H. pylori in the stomach.
And we've seen all this in practice.
Yeah.
This is not just out of research. We've seen all of this in practice.
Right.
Yeah. And we've seen it be effective by treating the H. pylori.
So pretty cool. Pretty cool stuff.
And somewhere out there's a vegetarian saying, well, if I'm already a vegetarian, and how come my H. pylori is not going? It's because you need to take B12.
Yeah, you're vegetarian, go on the B12.
There you go.
Yeah.
There you go. So I think that covers it. Yeah? No?
Yeah.
Something more?
No, I think that's everything.
I think it's probably about everything that you need to know about iron, B12 deficiency, and H. pylori up until the latest data as of this morning.
As of 9:25.
As of 9:25, because I saw him on there looking it all up this morning before we came online. So, and we try to keep up to date because right now there's just so much attention now finally being put on the uniquenesses of chronic pain. And although much of it's not finding its way in the medical profession because it's not resulting in a drug or a surgery, it's certainly something we can use here. You were even talking about different dosings yesterday of B12 and lysine for viral infections and stuff like that. And each time that Doug Gates comes across this, we'll try it and see if it works or not. That last combination, maybe that's something we should talk about, viral infections and stuff. I'm writing all these things down because this poor guy has to think up of a subject every week for us. And I have patients talking to me every day, all day long, and I'm thinking, oh, we should talk about that. Oh, we should talk about this. So, but anyway, I think that covers it. And again, hopefully you enjoyed this. Those of you who have an interest in this particular subject, it is very common. We talk about subjects that are common, whether you know it or not, that they're common, you now know that they're common. And you can share this with your friends. Again, if you have any questions, if you have any specific questions, I think we've covered it, but feel free to email us at
powerhealthtalk.com.
Yeah, .com, or see us on our Facebook thing. Are we still on there?
Yep.
Can tell I'm not the computer guy. And Doug Gates usually is very good at asking me what the answer is, and then sending you the answer like he thought of it or something like that. I promised myself I'd make him laugh twice today, and I got him both times. So we'll see you next week. Thank you for watching.
Thank you for watching.
I love it. I love it.